All right, welcome and thank you very much everyone for joining. Particular thanks to Rod and Jens for the invitation and everyone at Seattle Science Foundation. I wanted to take a little bit of a different approach for this talk to the residents and fellows because we've had just an agenda of an amazing bit of topics on technology, techniques, complication avoidance, and for those residents, fellows, want to just throw out the strategy or the process of how I got to outpatient hospital-based lumbar fusions. There is a full-length edited video of an MIS robotic T-lift that you can look up on YouTube at another time. So, the stated objectives are the ones there, but what I really want the residents and fellows to think about with this talk is, how did I get to where I am now as a private practice neurosurgeon over 20 years now? And that's the concept of lifelong learning. And the 100,000-foot view, again, is comprehensive learning. So we've heard some amazing talks on techniques and strategies and complication avoidance. And sometimes I think we learn things in silos a little bit and forget the bigger picture. And I always remember something my dad told me when I finished my neurosurgery residency, and he's now a retired educator in radiology. And he said, don't think you know everything about neurosurgery just because you finished a neurosurgery residency. You're really at the beginning of your learning process and learning in your career. And so with that, I wanted to share with you my process of getting to outpatient hospital-based lumbar fusion. I've been in practice for over 20 years, and for all the young guys, I finished residency at a time where pedicle screws were actually illegal to be placed. My practice is now a lumbar degenerative practice, but I became an early adopter of some of the newer techniques, which are now maybe older techniques, and that includes MIS, image guidance, biologics, and robotics. So what were some of the factors that affected my practice that got me thinking about doing lumbar fusions in the future or currently? The first is our COVID pandemic, and I'll talk a little bit about that. The second is the opioid crisis in the country that we're all sort of dealing with that really kind of ramped up about 5 years ago. And the other is the aging population of patients. I live in Tucson, Arizona, where the 75 and 80-year-olds are disgustingly healthy and ride their bicycles more than I drive my car in a week. Part of what I was looking for is, how does the economics of private practice neurosurgery and spine surgery, how does that affect what I want to do as a surgeon in the future? And then again, for the younger guys who don't think about their mental health and their physical well-being and have young families when you're residents and fellows, I encourage you to start thinking about that so that when you're old and gray like us, you have not missed the opportunity to enjoy all of those things in life. So the COVID timeline, we all had a separate timeline, but I'll just quickly go through this. In Arizona, mid-March, we were not allowed to do elective surgeries, whether they were outpatient or inpatient. That had to forcefully cancel about 20 cases on my schedule. We were able to resume elective surgeries about 6 to 8 weeks later, but only in the outpatient setting. And then about 3 weeks later, we were allowed to resume inpatient surgeries, but only if we did not put them in the ICU and if we could guarantee a very short hospitalization, in other words, 1 to 2 days. So the COVID pandemic really caused us to relook at what we were doing. And in my practice, it afforded me an opportunity to see if I could reschedule some of these canceled surgeries and turn them into normally a 1 or 2 day admission and maybe transition them into outpatient surgery in the hospital setting. We can continue to do our outpatient discs and laminectomies and even 1 and 2 level cervical fusions, but how about our more complicated lumbar fusions? The opioid crisis in the state of Arizona, about 2014 or 2015, state legislation came about, administered through the State Board of Pharmacy, that put significant restrictions on all of us, and this is probably similar in your state. So new restrictions on prescribers, new prescriptions on prescribing, mandatory electronic prescribing, required to review, as practitioners, we review the State Board of Pharmacy website. There's a maximum on 90 morphine milliequivalents a day. There's a maximum quantity of the number of pills you can give, 5 to 7 days. You can't give pain medicines more than 90 days unless you have a contractual relationship or you send them to a pain clinic. And also the electronic monitoring of patient and prescriber data. Yesterday, we got an email from our hospital. We are no longer allowed to prescribe opiates for more than 3 days without putting a medical necessity on the chart and an ICD-10 code. So people are forcing us to look at the way we practice medicine and do surgery. So the opioid crisis allowed me to kind of relook at how I took care of my pain patients and post-surgical pain patients. It created an opportunity to look at ERAS protocols, something I learned a lot at from Mike Wang, who was on earlier. And that is the enhanced recovery after surgery protocols that were really sort of envisioned early on with OB, general surgery, and orthopedics. And again, allowed me to see if I could improve the patient experience by reducing the need for opiates. Again, my patient population here in Arizona is living longer and longer. Besides being longer, they're much more healthy. There's a lot less smoking. They're a lot more fit, do a lot more recreational exercises. And all of the common diseases that we all take care of are commonly more common as these people get older. And that is lumbar stenosis, degenerative spondylolisthesis, adult degenerative scoliosis, and unfortunately, iatrogenic instability, PJK, revision surgery, and the like. How about the economics of spine surgery? Oops. Whether you're in private practice or in academics, there's certainly a push for high volume surgery, high quality surgery. And in the past decade, there's been this aggressive movement to shift spine surgery to the outpatient setting. We know that there's good evidence for quality and outcomes, patient experience, and perhaps income streams for surgeons. If you're an owner in ACS, we know that there's good data about reduction in complications and cost of surgery at ambulatory surgery centers. But there potentially are some limitations, including postoperative pain for our bigger operations like lumbar fusions, and perhaps earlier complications when we do these at outpatient ambulatory surgery centers. So taking all that in mind, I wanted to try to improve my lumbar fusion patient practice, and that included continually evolution of improving my surgical workflow and techniques, minimizing my workflow, maintaining efficiencies, improving or maintaining results, improving patient outcomes, and again, as a dad and a husband, try to preserve my mental and physical health the longer you go in your career. So these are some of the things I wanted to specifically address: improving patient outcomes, returning them to work and life passions quicker. For a surgeon, I wanted to reduce my fluoroscopy exposure. Again, as a son of a radiologist, my dad has several friends who have ultimately gotten bone marrow cancers, probably from not protecting themselves. I hate operating on patients and rounding on patients. I love operating on patients and not having to round on them. And I wanted to create some excitement for the rest of my career, and again, improve my lifestyle sort of as I got older and less healthy. So how did I get there? I adopted MIS techniques. I adopted a simplified ERAS protocol for managing post-op pain. I adopted patient education as a unifying principle of spine surgery and taken active involvement in patient education. And I did this with an ERAS type protocol, which is a stepwise approach over many years. I just didn't do this in the last year. So you examine your technique, you examine your process, you evaluate it, you change it, you adopt it, and you re-examine it. Something I learned really well from Mike Wang. So why adopt MIS techniques? Lots of literature now, over 20 years experience. Reduces pain, reduces infections, reduces length of stay, reduces complication, may reduce cost. We can maintain and improve outcomes, all of the different outcomes we measure. We can get patients back to their lives faster. Tubular retractors are the mainstay for MIS techniques for decompression and fusion. Those are the list of the common ones. The addition of image guidance can certainly enhance pedicle screw accuracy, reduce the risk of pedicle screw mishaps and complications, particularly for complex anatomy and revision surgery, and again, reduces fluoroscopy exposure. The added value of robotics technology has been very, very helpful. So now that our robotic accuracies are probably close to 98 to 99% with pedicle screw accuracy, and you've seen an excellent cadaveric demonstration already about one robotic system. Further reduces fluoroscopy exposure, and we're just the tip of the iceberg with all of the future applications for robotics in spine surgery. So my lumbar fusions, I've adopted MIS strategies for all of them. The powerhouse for me is a TLIF or a PLIF. Have added lateral, including a DLIF, XLIF, and OLIF, as well as standalone with image guidance and robotics. How about ERAS protocols? Sort of stole a lot of different things from a lot of different services. IV Tylenol is too expensive, Exparel is too expensive, so we developed a very, very simplified protocol, which includes pre-op medications, acetaminophen, Celebrex, gabapentin, no fancy anesthesia, still general anesthesia. We don't have to do awake patients. I use epidural morphine and depomedrol judiciously, generous infiltration of lidocaine and marcaine, and a very simplified post-op pain medicine protocol, which has eliminated PCA pumps, eliminated IV PCA PRNs, dramatically reduced all the complications related to those medications, reduced all of the adverse effects, and dramatically reduces phone calls to the office, which I always hate. Here's a quick look at my medication protocol, and you'll be able to look at that on the recorded version as I'm out of time. Patient education, as surgeons, we should embrace that and do that ourselves. There's lots of evidence that shows that when you do the education, it improves outcomes, reduces complications, reduces your risk of litigation, and patients really appreciate it. Do that on your website if you need to. Oops, I'm stuck here. There we go. And so the results of MIS surgery in my practice, we put together a talk and found 5 surgeons over 1 year. We had dramatic length of stays for those that used an MIS strategy for decompressions and fusions. We found that the total MMEs for morphine were 1/3 of open patients. It was independently a factor in improvement. We hope to publish that soon. And then the final results of early MIS surgery, ERAS protocols, and patient education is getting to the point of doing outpatient lumbar fusion. So I have a single surgeon observational series, just a preliminary report of 9 patients. 5 of these were done in the COVID era because they didn't want to stay in the hospital full of COVID patients. And set a goal for yourself. So as residents and fellows, my goal is this next year, I want to get to 25% of my fusions being lumbar outpatient, and by 50% 2-year. And here's the final slide, which is a snapshot of the data that you can achieve with that. Here's 8 or 9 patients, including one that I did this week, was a 3-level TLIF. These are all reasonably healthy people, but they're not all young. And with reasonable OR times and PACU stays, these patients can be discharged home with minimal risk of complications, minimal rates of return to the ER for prescription pain medicines, urinary retention, and the like. And here's the picture of the guy that I did earlier this week. And then finally, as a note, set up a goal for yourself to learn new techniques and new technologies. They're rewarding for you as a surgeon. It requires you take some time. It requires you to take some reading and analysis, take some risk and get out of your comfort zone, and learn how to adopt some of your failures so that you can make it a better option for your patients. Success is not always final. Failure is not always fatal. Always need to have the courage to keep learning. And with that, I'll end. Thanks. Sorry for going over time.
Thank you so much, Dr. Chua. That was insightful and taken to heart. You know, I think that it's always important to try to push yourself to learn new things and advance in your treatment of patients. I appreciate it.